Internationally, our inguinal hernia operations, not only is it one of the most common elective surgeries that we do, but it was also really significantly down prioritized in much of the world during COVID-19. And in many ways, the way that our systems recover from this gives a bit of a barometer for how we're going in each of our countries during our COVID-19 recovery. So in terms of our background, we're obviously particularly interested in looking at our compliance to audit standards. And within the United Kingdom, the recommended waiting time is 18 weeks for surgery after referral from a general practitioner. We therefore anticipate that with fewer planned operations, that we've likely had an increase in our global and also potentially that we've had an increase in emergency surgery for complications of our hernia. As we wrote the protocol, there were nearly 75,000 patients waiting within the United Kingdom for inguinal hernia surgery. And I guess all of us in our own countries can reflect on potential reasons for global variation. And we're particularly interested in exploring the reasons for these variations as part of the study. And so perhaps whether it's age, type of hernia, the symptoms that our patients have had, local effects of COVID-19, and our national resources.
Hello.
To give you a little bit of perspective on the within Australia, and this is based on a current Australian Institute of Health and Welfare data. The recommended wait time in Australia is for symptomatic hernias 12 weeks and for reducible asymptomatic hernias 52 weeks. In New South Wales, which is one of the major states within Australia, we've had a significant decrease in the number of patients that have actually been done. And so we've had 32% fewer operations done. We've also had a decrease in 12% in the number of new patients added to our waiting list. And we have a 10-year high on patients actually waiting for elective surgery. And so if we look specifically at the study aims with respect to the waiting list, we're very interested in one of our primary aims is auditing compliance to standards, and specifically with the first part looking at waiting times. One of our secondary aims is to understand the impact of the waiting times on inguinal hernia patients. And as I said, to try and identify factors associated with longer waiting times. And I guess consequently, identifying the global scale of our backlog will help to inform policymakers on optimizing strategies for addressing it. When the study was designed, we were looking at modelling for 1,000 centres and 5,000 patients. And as of last week, and I'm sure Maria will be able to update us, there were 3,700 patients and 250 centres. It's clearly really important as we come into the last couple of collection periods for each of us to look at maximising the number of centres involved. And certainly within Australia, we're still working very closely with some hospitals to try and get their ethics approved so that they can join us with data collection. So for HIPPO, this is clearly a national audit, and all data is designed to measure current practice, and we're not planning to change normal patient pathways or treatments. And in terms of thinking about the waitlist time, we're obviously interested in the time of diagnosis, be that incidental or symptomatic, the time our patients are waiting for surgery, and whether they end up with elective surgery or emergency surgery, and some of the factors with respect to the hernia itself. So the size, the type, the symptoms that it's causing our patients, the effect on their daily activities.
there's so much variations to look at in the management of inguinal hernias across the world. It's very, very, very likely that HIPPO study is going to be throwing out a huge number of exciting findings in terms of variation from across high-income countries to low and middle-income countries. Apart from that, the issue of the technique is one of the main things that we're collecting in the data sets of this study. For instance, I particularly am really looking forward to know how many hernias are repaired open compared to laparoscopy, and how many surgeons are deploying the robots to repair inguinal hernias across the world. We're going to be seeing all of these. The use of anesthesia, the kind of anesthesia that is employed for repair of inguinal hernia, is going to also show us the variation across the world. I definitely think we're going to see a lot of variations in terms of the use of mesh and the adoption of non-mesh techniques. Of course, in low-middle income countries across the world, we've had different things being used for hernia repair. I think we're going to really learn a lot in terms of what techniques are deployed in which parts of the world and for what types of patients and what categories of hernia are these deployed for. I think we're going to learn a lot from the outcome of this study. Another fantastic thing that this study is going to help us to look at is who are the people performing inguinal hernia repairs in which part of the world. I think we're going to see a lot of senior surgeons. We're going to see a lot of trainees. We're also going to see perhaps medical officers. And I also know that we're going to also see parts of the world where non-doctors are involved or directly lead hernia repairs. And incidentally, this is going to lead us into future studies. For instance, the TIGER study that is also being planned by the Global Surgery Collaborative that will be starting in Ghana, where the task shifting randomized control trial of looking at surgeons performing inguinal hernia and non-surgeon technicians that have been trained performing simple, uncomplicated inguinal hernias. I strongly think that we're going to learn a lot from HIPPO, and I'm already looking forward to the variations that we're going to all be fed with in the outcome of this study.
Explore the uptake of environment sustainable practices well around the world indeed. So, well, I just would like to remember that this week, just a week ago, in 2023, just few days ago, the IPCC-AR6 report was released, by more than 8,000 scientists worldwide who are studying the climate change. So it summarized the state of knowledge of climate change and of course of the risk and impact of all of this problem, this enormous problem in the life and the mitigation and some adaptation strategies. So, well, the bad thing is that there is a rapidly closing window of opportunity. And as a people who are, part of this environment, almost all we are involved in some way in the strategies we can do for helping on reducing the climate change. So unfortunately, the time is almost over, and most of predictions says that with current implemented policies, well, unfortunately, they are not enough. So we have to aim to reach a net zero surgery, which is, we know that healthcare is responsible for 4.6 of world greenhouse emissions. And at each hospitals, from that amount of greenhouse emissions, the operating room is accounting for around 25%. So robust and evidence, unfortunately, and proven strategies are lacking nowadays. So multiple interventions or different strategies are needed to this complex area. And we need to inform further studies, further strategies by making a great baseline of how the people are addressing all of this stuff inside of hospitals. So that was the reason, because considering inguinal hernia repair is a very common procedure, it can reflect the global uptake of environmentally sustainable measures. Of course, achieving a net zero health system is only possible if reducing the carbon output from operating room theaters is included. And from a very recent scoping review of the global surgery team, we know that there are almost 5 big strategies in which we can act from now to change our future. Some of them are anesthetics and surgical gases, energy use, consumables, wasting, and other strategies maybe less important. So in relation to HIPPO study, we aimed to describe a baseline of different practices to inform future studies, considering all of these 4 scenarios we are talking. So the first one is anesthesia, and you know that in many situations as anesthesiologists, we have the option to choose without affecting quality and safety by using some way of prioritization of the patient. 50% of the OR carbon footprint came from anesthetic gases. So that's quite important when we choose the strategy of anesthesia. And of course, there are plenty of information about this worldwide. And the second area, we are talking about the use of mesh, and we are trying to describe how people worldwide use this during inguinal hernia surgery. And also, as part of the Western change, what about the excess of mesh? What people is doing now with that? And is it reused, or what is happening? What is going on there? Regarding reusable drapes and gowns, so OR can generate up to 1/3 of the total hospital waste. So we need to think about these possible materials and single-use devices, and HIPPO is addressing this. And finally, about recycling, in which we have several strategies inside operating rooms, including waste segregation inside.